Our fourth and final learning collaborative with Dr. Chuck, Charles Browning, and Joy Brunson Nsabuga. And today we are focusing for this fourth and final session on outcomes-driven continuous crisis care system improvement.
My name is Joy Brunson Nsabuga, and I am the Vice President of the Southeast for RI International. I am based in North Carolina, and I oversee operations in North Carolina and Louisiana as well. My expertise and background is that I am a clinician, a licensed marriage and family therapist, and a licensed clinical addiction specialist as well. And I specialize in crisis services implementations, adding in substance use services and medication-assisted treatment to care, and then also DEI initiatives as well. So I'm going to pass it over to Dr. Chuck to introduce himself.
Hey everyone, I go by Dr. Chuck. My full name is Charles Browning, and I'm the Chief Medical Officer at RI International, and also the Medical Director at Behavioral Health Link, which does crisis call services, call lines for the state of Georgia, as well as 2/3 of the state mobile support teams that are now doing that outside of the state of Georgia as well. So I tell you what, Joy, I've got mixed feelings about today. I mean, this is like, we're talking about outcomes. The outcome of my mixed feelings is like, I'm so excited to present this wrap-up session of the fourth one and meet with everybody, but I'm sad. Like, this started back when I had less gray hair a year ago in October. And we started working on this, and a lot of you, as you said in the poll, have been here through all of these lessons. So I hope we can do a good job today in helping kind of take to the final step of thinking as you put these systems together, what kind of outcomes are you looking for, and how do you evaluate those, measure them, manage them?
So learning objectives, we had 4 learning objectives over the series. So throughout the entire kind of series of presentations, we wanted to ensure that you guys were provided data and real world examples of research and context for behavioral health crisis response systems in the US. We wanted to ensure that you had information on the intersection of disparities and inequities in the system. And then also that you were able to learn about the most up-to-date information on innovation and technology in the crisis continuum space. And that you were able to analyze your own behavioral health crisis response systems to determine foundational elements, trends, positives, and of course, areas of improvement. So hopefully over the entire series, you were able to gather this information and then bring it back to your own crisis systems and start to analyze where you are now and where you would like to be, basing that on the national guidelines and principles.
All of these essential care principles are the goal of the way that we're interacting and supporting people in our community as we roll out these crisis continuum services of an equivalent to 911, an equivalent to EMS, and an equivalent to emergency departments. So today we're going to kind of branch into covering suicide safer care, and a little bit also about the coordination and importance of being able to manage certain substance use issues in all of the crisis continuum, as then go into kind of the macro section of the overall final steps. How do you put it all together in terms of outcomes? So when we talk about safer suicide care, well, one of the things that often people hear about is this organization Zero Suicide, and it's just a concept with a audacious goal that in the context of healthcare organizations, that using the right evidence-based practices, having a goal of zero suicide in people that have encountered and come into contact with healthcare. And so there's some general principles about that that are really important to think about as you're designing your crisis system. Number one is in all elements, whether it's a call line, mobile support team, crisis receiving center, or other areas of the continuum, screening and evidence-based screening tools are really important. So being able to ask people about suicide and suicide risk. We're going to talk a lot today about how all these elements, when we look at outcomes, have impacts on, including that we're being inclusive and appreciating diversity. And one of the things that's really come to light in this past couple of years during the pandemic has been a highlight of some of the screening issues related to people of color. So looking at young Blacks population coming through and identifying some of the typical screening questions of saying, I have suicidal ideation, was not necessarily always an adequate question, that there were more concerns and measures of emotional pain and burden, feeling hopeless, and those types of questions that were directly involved with cases of suicide attempts or death by suicide in that population. So one of the things as we go forward and talk about outcomes today, we're going to talk about making sure that your system includes and thinks about all of these different arenas. So screening is important. The next step is, if you have a screening tool that helps identify as many people as possible that would be at higher risk, then having the appropriate assessment tools. So in a call line situation, that call staff needs to be able to have the right assessment tools to decide, is that person with active engagement being able to stay at home and with appropriate follow-up and connection to supports safely, or do they need a higher level of care, like having mobile support come out to see them, or actually go to a crisis receiving center for a higher level of care. Mobile support team also is going to be doing that same thing. Hopefully after having an identification of screening already, going in and doing assessments. And the overall goals of an assessment is to be able to get risk factors that we know are evidence-based risk factors that put someone at risk of harming themselves imminently as well as in the future, but then have an active engagement with them to have the least restrictive environment as possible to help support them and move forward. One of the saddest things about our current system is so many people that I've talked to, either patients I've worked with or speakers I've heard who have lived experience with suicide and suicidal thoughts, is the concept that they say, I will never call 911 or go back to the emergency department again if I have suicidal thoughts. No way, because of a traumatizing or unhelpful experience. So as we're designing our systems, I think one of the most important thing is going back to those recovery-oriented practices that you should implement. And that means being able to be collaborative and engaging and work with people on those things. So another piece to it that's really important in the concepts of safer suicide is having direct treatment available for suicidality. So there are evidence-based treatments, different forms of dialectical behavioral therapy or DBT, cognitive behavioral therapy specifically designed for suicide prevention. Those are really important elements to have. So in crisis, a lot of times things get focused on, treating depression, starting an antidepressant, dealing with different social determinant stressors. But it is really important to talk about suicide, talk about the things that help create increased capability for acting on that suicidality, talking about supports and engagement and things that person can do. And that leads into safety planning. So safety planning is a collaborative partnership working with someone so that they can design and talk about the things that they deal with related to suicidality, triggers, warning signs, things that work for them in the past when they have those symptoms to feel better. Who are the supports that they can lean on when they don't feel well enough and they don't feel in control of that? If they need a higher level of care, what do they want to do during that? And the coolest thing about that is there's multiple tools that are evidence-based. Many of them now are free apps on cell phones. So whether you're a call line, mobile support team, or working at a crisis receiving center, there's an option to be able to help partner with someone if you have the training of how to do safety planning to help them design their own plan on their own phone that has their own contacts of who to call and things of that nature. And then part of wherever you are, whether it's in a call line service, a mobile support service, or a crisis receiving center, having follow-up is a really important next step too. So when we talk about, that first 7 days, 30 days after a suicide attempt or after being hospitalized for suicidality, for example, is a really high risk period of time. And so working with that person collaboratively to have appropriate follow-ups, and especially a caring connection. So thinking about in your systems, whether it's a note card to the person, a phone call, if you're transitioning that person to a new outpatient care provider, possibly having a mechanism built in where they can, and this is being done in some places around the country, where they can do like a televisit to just introduce the person they're going to be seeing when they come to their appointment 5 days later, to say, hey, can't wait to meet you, and we're going to really work on this together, that kind of thing. And then finally, the technology pieces is having a way to access and see the information, to share safety planning, to be able to look at screenings and assessments that have been done and be able to progress that through someone's work, so that it's not just in silos what's going on with someone and other people can't see it. And that's a real challenge in communities. So as we finish up talking about Safer Suicide, Joy, any thoughts about some of the community challenges and outcomes and other things that I didn't cover?
Well, I think you covered most of it, but I think it's important, because we're talking about communities and we're talking about systems. One of the big things is not to be siloed. Chuck, when we were talking about earlier in planning for this presentation, we were talking about how the community stakeholders in some of the areas that we operate in have started to come together to provide this foundational support across the entire continuum. So when someone is interacting with the detention center or the hospital or law enforcement or EMS or community paramedics or the behavioral health system or urgent cares, like there are forums that have been created to make sure that information is also shared across platforms, so that each encounter can be very meaningful. Each encounter, that individual kind of knows the background and the history, and then also if something happens or if someone needs additional assistance, then that information can be brought back to the behavioral health system as well. Also being tied into the recovery community, peer sports specialists, and being able to have peer sports specialists on your team who are very ingrained and involved in the community can also help to support just different stakeholders not being siloed, especially when individuals' lives are at stake and we are able to provide that extra layer of support at the community level. If a provider or stakeholder is kind of off by themselves, it makes it very difficult for that community perspective to be able to support individuals when they're having suicidal thoughts or need additional supports and in care. And then also for maybe a stakeholder, law enforcement, or our community paramedics who may not be as comfortable supporting individuals that have suicidal ideations, they know that they can also call mobile response, or they can call a group of people in to help them also support that individual. So it's support for the stakeholders, but it's also ultimately support for the individuals that we are serving. So really getting dialed into the community really makes a big impact on the individual's care and how they feel supported.
And Joy, while we're on this one last slide, let's talk just a little bit about outcomes. And as you're designing your system, what things do you want to measure? So when you're talking about, and I'm talking about specific measurements related to suicide care, we're going to go over some more general measurements for each of the services in a later part of our talk. But I think, when you're looking at suicide, you want to make sure, you want in a crisis situation to have 100% success rate in screening for suicide risk. And you want to be able to measure that. And just as I mentioned when I was talking about screening before, from a quality improvement perspective, if they weren't measuring and looking at in research different demographic groups and how they responded to the classic what questions that often are in evidence-based practice for screening, such as the Columbia Screener tool, they would have missed that certain questions might not work for all groups. And so that's that continuous improvement. If you're not measuring that, looking at it, then you can't adjust the types of screening tools that you would use. You want to be able to measure that you're identifying access to weapons and helping people who are at high risk with suicide, get those things protected so they decreasing means and easy access to that in the short term while they were dealing with really strong challenges with suicidal thoughts. You want to be able to ensure that people get access to safety planning if they are identified at high risk. You want to be able to make sure that you have measurements of how well you're doing with follow-up and connecting people. You want a scale of suicide risk in an ideal scenario that you can follow for improvement or lack of improvement throughout time. So there's all kinds of measurements specific to suicide that are being used and are out there that you want to think about the powers that be that are looking at continuous quality improvement and are you doing things well, and also researching what interventions help most, because that's still, we've got a lot of room to grow and get better at that to serve all folks. There's so much more to know and to understand about this. So just be thinking about those types of things as you're developing your systems. Also develop systems to be able to measure certain things and people to own those outcomes so that they can react and measure and manage what you do in your community.
So on that same vein, Tara had a question. I'm curious what percentage of crisis interactions are able to be safety planned versus hospitalized. She said, we just started tracking this data about a month ago. What are your thoughts on that? Safety plan versus hospitalization?
Well, it depends on the area and the data that you look at, Joy. But for example, the National Suicide Prevention Line sometimes has numbers as high as up to 90% of people in the call lines with active engagement and the right kinds of supports being able to be supported within their community without and connected to outpatient follow-up care without needing a higher level of care, such as mobile support or going to a facility or hospitalization. So those numbers can be pretty high when you are doing the right kinds of things, screening, engaging, working on being connected with that person. And that's a whole concept with National Suicide Prevention Line, is this active engagement, targeting a collaboration towards a least restrictive intervention. With mobile support teams, for that group that does need mobile support called out, they range usually somewhere between 70 to 80%, 85%, depending on the numbers and what state you're looking at, and being able to help those people stay in the community. And then, the work that we do at RI, Joy, we see in our crisis receiving centers that, as high as 60 to 70% of people that come into the 24-hour observation unit, which would be the equivalent to an emergency department, are able to be returned to their community. And then of those group that need a higher level of care, when you have other continuum like short-term inpatient stays, oftentimes that's another pocket of 60 or 70% of that group that are able to be safely discharged within a few days, 3 days, 4 days, something like that, without being in a long hospitalization. So you end up creating the right fit for the right need in that situation when you have the appropriate practices and the appropriate infrastructure in place to be able to do that.
I would put a plug here that one of the practical applications of that, some of our work in the state of Louisiana, one of the things that they just added into their mobile response system and continuum and service definition that has just been implemented in the last 3 months. So no data yet, but thinking ahead, adding in that reimbursement for follow-up after someone has called and needed a mobile response visit, then also adding in the opportunity for that same mobile response team to go back out the next day, and then again within 72 hours. So just thinking about that safety planning, assisting individuals with staying in their community, that's also another way that they have worked to develop that continuum. And we'll see in the next couple of years, hopefully a year, to get some good data on what that is going to look like and what impact does that have. And to answer your question, Orlando, the team is made up of a clinician and a peer. So it would be that same team going out to see the person the next day, and then within 72 hours if that's what's needed.
I thought of one last thing while we're on this topic of safer suicide care, Joy, and that would be, going back to the essential care practices, one of those is coordination with law enforcement and emergency medical services. So when you are working on a crisis call line, there may be times, and you have to have the infrastructure in place, that if someone calls you and they have just taken an overdose or are in the middle of an attempt and have cut themselves or things like that, you have to have pathways and protocols of how you can activate 911 for immediate emergency medical response. One of the challenges that's being debated across the country right now federally with 988 is we allow GPS location on people's cell phones for the 988 calls. And it's situations like this right now, it's not. And you're going to be just go into whatever area code your cell phone is will direct you to the call. But in 911 calls, it does. And if you have a medical emergency and then disappear off the call, they're going to be able to geolocate you. So there's just elements of things like that to think about. Mobile support teams, if you're going out to where someone has an active weapon and is an active attempt, there's going to be some type of coordination between the mobile team and law enforcement from a safety perspective. So there's different elements that are tied into design of your system of how you coordinate that with emergency medical and emergency law enforcement services, just to have that as the final thing.
This is another area, the introduction or inclusion of substance use, being able to also assist individuals when they call into a call center that may be under the influence or may need support. And it's more on the substance use side, and then also for that mobile response visit as well as that facility connection at the end if that's what's needed. And so this is actually a 2017 slide, and unfortunately in the last 18 months or so, we've seen the number of overdose deaths tremendously increase. Where this was around 50,000 a year, we're now well over 100,000. And with that data, we know that there is the need for the inclusion of substance use screenings, assessments, also that expertise when individuals go out on a mobile response visit, and then also in the facility aspect as well. However, with just the data pieces of it, we are now seeing that we know the numbers, but we're not sure what the data means. There is the question of intentional versus unintentional overdoses, and then also is it a means of for individuals who are in despair. So we're just not completely sure what the numbers actually mean, but we do know that we are in that fourth wave of the epidemic now, with the inclusion of fentanyl and everything else. And so being able to work within this system, make sure that we are providing care for everyone, having the capabilities of working with individuals that have substance use concerns as well, because oftentimes we see that there are co-occurring disorders when individuals are in a full behavioral health crisis. This is just one of the examples of a community continuum that we have developed. This is out of one of our North Carolina locations and communities, where we really have been able to engage the hospital system, the detention system, first responder referrals, whether someone walks in, and just being able to funnel individuals into care, whether that's mobile response. And this is specifically for individuals that have substance use, but then also opioid use disorders, and being able to offer within that continuum evidence-based practices, including medication-assisted treatment. So being able to ensure that no matter where someone kind of enters the system, that we are creating that parity, whether someone's on mental health medications or medical medications, but also offering medications for substance use as well. And then being able to offer those options, whether that's the recovery community connection, physical health care, or a community referral, but also including medication assisted treatment within our crisis facilities, being able to provide that screening tools and those assessments if someone is going out on a mobile response call, so they know where someone needs assistance, especially when it's a substance use challenge. And then also on the other end, we talk a lot about being able to then transition individuals into the community. So utilizing peer navigation or peer bridger programs, outpatient programs, all of those to make sure that the system is connected from the time someone enters to when they're back into the community. So this is just an example of how, as Chuck and I was talking about earlier, having that community approach, so that individuals are not falling through the cracks because an agency might be siloed or the detention center might be kind of off doing their own thing, but being able to really get connected together to support the community and the challenges that they have. In this particular community, we discovered that we had a pretty significant percentage of individuals that were dying from fatal overdoses. So bringing everyone together to determine how are we going to address the challenge and support the community was really important.
As you're looking at the system, you want to make sure that all elements of your call line, mobile team, and crisis receiving centers screen for opiate use disorder. It doesn't happen a lot as a universal thing in a lot of emergency services. So people will usually only get identified when they do a urine drug screen for something else and it shows up in their urine drug screen, or they have an accident or they have an overdose and are brought in. And so as we design systems, our 988 number is not designed to just be a suicide prevention line. It's designed to screen for and support all crisis issues. So having those kinds of abilities to ask questions about it. And then when those are identified, having the appropriate direct treatment of opiate use disorder and knowing what the access is in the community. You and I both know from work we do in consulting it is like figuring out how to navigate where you can go get help for opiate use disorder within communities. Is if you know one community, There's no like universal standard of how to get access to care, and there's so many barriers. And I know you're going to talk about that in the next slide, but as you get that system, be thinking about those things, and then going back to follow up and safety, having connections that support people in their next steps is another important safety issue, just like it is for suicide risk. And this things like naloxone, harm reduction concepts, connection and engagement into the next steps of care are really important.
And another kind of practical application, since I'm on the ground per se in a lot of our locations, a simple thing as adding in, especially during this fourth wave, fentanyl dips into our urine drug screen point of care concepts, and then spreading that information to the detention center, to the hospitals, to just making sure that we're all looking for the same things will also influence that overall care. We don't want to be looking for something that our partners in the community might be missing or not aware that they need to be checking for as well, especially when we know that there is a substance, fentanyl in this case, that is becoming increasingly more prevalent. It is another way that we are supporting our overall community, but also offering different assessment tools and resources, and then how to connect that to education for the person being served, what's next for treatment, and all of that. One of the things that is really important that we found, especially when it comes to substance use in systems, is this pull between philosophies of thought. So when you are thinking about how to implement any of these additional services into your overall crisis continuum, from again the call center to the mobile response team to your actual facility or crisis receiving center, these are just some things that we wanted you to be aware of, especially in the substance use recovery community, that there are different schools of thought that can sometimes start to bump up against each other. And considering detox versus abstinence only programs and kind of that model versus harm reduction models and different types of services under that vein. Looking at the differences between disparities of individuals that may not have access to care, individuals of color, lower income individuals in rural areas oftentimes don't have the same access, as programs are usually geared towards people that are in more urban areas or ones that have insurance or funding to be able to support treatment. And then also looking at the difference between the disease model of addiction, and then also on the other side, criminalizing individuals who have substance use challenges. So these are the things that get kind of overlaid across a system that we have seen have to be resolved in order for that system to start moving forward. Once you kind of look at that system and look at all of the things that are starting to pull against each other, these are the top 3 ones that we have found really make an impact. And that is looking at the access, breaking down those barriers for individuals who are not able to actually get access to the care that is available. So what are those criteria that you have for those different programs that need to be kind of dismantled? A clinical fit to need, making sure that there's multiple levels of care, and then making sure that we are having evidence-based practices and then recovery-focused care.
What do we think about, Joy, when we talk about specific outcomes for managing opioid use disorder within the crisis continuum, when you're thinking about things you'd like to measure at different levels in the community?
Things that are important to measure within a community when it pertains to substance use treatment and the crisis continuum. Again, you want to look at not only access, the number of individuals that you have coming in, but also how are we screening and how are we identifying individuals that have a substance use disorder. We would like to look at the timing. So from the time someone is identified as having a substance use challenge to the time they actually get into full care. That time frame is really important, especially for individuals that have the opioid use disorder, because that time can really be the difference between life or death for them. And so really making sure that we are providing that immediate access into care, that time, that place, kind of being able to go now. And then after being either visited from mobile response or being treated within a facility, that time from that intervention to their next level of care. Again, these are areas where individuals can tend to be dropped in the system. So for us, it really is more of a timing issue, and making sure those appointments are next day, 24 hours, and really getting individuals into care quickly, because we know from research and looking at some of the work that was done with the Yale core model, is that when individuals are in crisis and they are offered treatment at that time, they're more likely to stay in treatment 30 days later, especially for individuals that have an opioid use disorder. So that's the mantra that we go off of, is really that timing and access.
So you'd be thinking about measuring percentage of people that get screened and asked about opioid use disorder, time it takes for them to get into care of treatment if they choose to do that, number of people that are offered Narcan or naloxone as a harm reduction measure for overdose prevention as they leave a service. You, as a community, you want to track demographics and look at how well you're serving different groups of people and how well you're engaging with them. If you don't look at the numbers of how many people you're offering MAT, and you might be missing, is there bias in your system that's affecting who gets offered what? It's a clinical improvement, and something I'm really proud that we've made progress on in some of the areas that we're enjoy, is the coordination with law enforcement and incarceration. So the people who are on MAT oftentimes get into legal trouble from things that are going on related to their substance use, and might be doing much better in with medication targeting the opioid use disorder, and then all of a sudden have to go to court and deal with an incarceration period, and oftentimes go through really bad withdrawal, be at super high risk of overdose on the day they leave their incarceration time. And so having systems in place to coordinate, and many more places around the country now, it's standard of care to continue MAT just as you would continue treatment for diabetes when someone is in jail, and have those systems in place. And then having specific programs, often led by peer support, in helping connect people the day they leave being incarcerated to get back into treatment that day, because it's a high risk, really high risk statistically area. So just some things to think about as we get into the discussion section for these two.
So our first set of discussion questions: what aspects of the essential care principles of the crisis system can be improved from a systems perspective? What are the current operational thoughts about care principles and call centers in your area, mobile transport, or crisis receiving centers? And then based on these choices, what are the potential impacts to your community system? Individuals with lived experience, out of our almost, I think we're at 1,200 staff members so far. So over 50% of our team has lived experience. And so that's where advocacy comes into place, making sure that not only are we supporting our own programs, but we're changing the mindsets of the funders and the state and all of that, because it really takes those advocacy efforts to be able to make changes, and then also having data and outcomes on the impact of peers within programs. It's going to be essential to have peer support specialists throughout the entire behavioral health continuum. And we don't mean like, off in an office and you pop in every now and then for a consult and then you go back. We mean integrated into treatment teams. We mean being in the staffing patterns and staff meetings, being integrated into care, going out on all of those mobile response calls, all of that, because the outcomes that we've seen when peers are integrated into services are just,
if you look at the SAMHSA's national toolkit and model, it is for extensive use of peer supports, and it gets even more specific than that. So in call lines, there's going to be many states that will use people with lived experience to be, they'll be supervised under licensed clinicians, but they'll be answering calls directly and on the front lines of doing that. And in many, as well as mobile support, even though there's different models of mobile support, the national toolkits model is a licensed person and then a peer, and the two team models that work that. And then finally, definitely the use of peer support in crisis receiving centers is integral to how our model works in creating that connective, recovery oriented approach that's very peer powered, as the words that we use to describe that. And so, you know, there are barriers, and there may be barriers in different areas, and they're in different lanes. Staffing is a trouble for all positions as we develop and work out this crisis criteria. But for the hiring of peer staff, you have to have support places in place for peer employment, funding for peer support being in there, and then, like you said, dealing with if there are significant issues related to legal things, how do you work with that? But we've also in our work encountered, you know, licensed clinicians and providers having background legal stuff that they have to deal with too. So it's not specific to someone with as a peer support job. All professionals have chances of some of those things being in their background and having to deal with them and navigate them.
So we are going to now kind of jump into the data, the outcomes, what you should be looking at, what you should measure, all of that stuff, and really kind of digging into those key areas. Of course, when we're talking about the areas that we are moving to, is really about transforming our crisis response for individuals that are in a behavioral health crisis, and making sure that individuals have that level of care and treatment that they need at the right time. So we just wanted to make sure that we're kind of understanding the equivalency that is coming and what we're moving to. So thinking about 911, we all know, call 911 whenever there is a medical emergency, and now transitioning to 988, that's coming next month for all individuals that are in a behavioral health crisis. So that equivalent of 911, thinking about 988 as being as being that equivalent number, but also with 988 having that kind of backing of a call center where individuals are also able to get that support through that phone call, and not the automatic kind of send out the ambulance. So that is one key difference. And then, you know, when you call 911, they are going to send the emergency vehicles and staff out to you to make sure that they're supporting you in whatever way that you need. And so thinking about the equivalent of the ambulance or police or fire, the equivalent of that when someone calls 988 will be the mobile response team. So that 2-person team, as Dr. Chuck has discussed, that clinician and that peer support specialist being the best practice, sending them out to a behavioral health call, again, a behavioral health response or a behavioral health crisis. So thinking about that equivalent. And then on the medical side, there are the emergency rooms, those places that you can walk into. If you're on vacation and something happens, you can still go straight to the emergency room for care. So thinking about that same thought process, that same access for the crisis receiving center on the behavioral health side. So no matter where you are, if you're in a behavioral health crisis, you can walk in to one of those facilities. The mobile response team can also take you there, just being able to provide that access. So really thinking about that parity and that equivalency with the medical system is really what's coming for the behavioral health side as well. As with 911 and that whole system, it didn't start immediately, right? It took years to build up to the system that we have today. However, we've got to start somewhere, and that somewhere is next month. And so we are going to be starting next month to build up to these crisis systems that will be able to support individuals when they're in a behavioral health crisis, and continue to build out these systems over time.
So Joy, as you described and showed that model of that slide, we've given today some specific outcomes to measure for like suicide. Last session we did talks about specific measures for recovery-based care and the use of peer supports. And we've talked today about measurements you could use in looking at how well you're doing with supporting folks with opiate use disorder. Today, now, or for the next few minutes, we're just going to go with some basic macro things to think about in these different levels: call service, mobile support, and crisis receiving centers that you may want to have to be able to measure, and just go through some of the things that are going to be important outcomes that are already being used out there to follow, but as you develop it in your system, to how do you build this in to what you're doing. So with the call center hubs, the main function, if you think about what you're trying to achieve, is 24/7, 365 answering for all callers in crisis. Then being able to have the tools and the training to be able to do screenings, assessments, engage with people, help de-escalate the number of people that as many as they can, to be able to be supported in their community, but then also be able to connect when they do need a higher level of care to mobile support or emergency medical or law enforcement services, and in the extreme of circumstances. So let's go to the next slide, Joy. We use these same categories for every layer of the crisis response to help talk about it. So we'll go through and just give some highlights for each one. So for the crisis call, number one, you want accessibility. So you want to be able to have two of the really important measurements that National Suicide Prevention Line call lines rely on is the average speed of answer. So how quickly, and it's one of the measurements that you get judged by and are part of your quality measures, is how quickly do you answer the phone when someone calls. And then second is called the ABN, which is an acronym for abandonment rate, even though I don't know how ABN fits to abandonment rate, but that's what it is. Because if you make someone wait too long, or if they're on hold while they're in a queue to transfer over to someone to speak to them, they'll oftentimes drop the call. And so that's a measurement that's followed a lot of times for accessibility. Going forward, we talk about accessibility measures like with different demographics. So how likely is a teen going to use the phone versus maybe doing a text or chat feature, which are really popular now and becoming a big part of crisis call services. Staffing outcomes are really important in managing call centers. If you don't have the correct amount of staffing per the amount of call volume, the average time it takes to do calls, and different factors, you just can't manage call centers. And there's really good models. The Erlang C model is a call center model that has equations that can easily help you put in different factors for your community and know the number of staffing that you have. And then if you don't have that, you can't just overproduce the volume and the availability to handle that. So as you're looking at that system, there's going to be certain outcome measurements with just your staffing that can help drive how you do. Quality of the calls is an important thing to measure. And so having mechanisms in place to have either live people with experience being able to rate and scan audits of certain calls randomly, or particular calls that didn't go well, can make a big difference in continuous quality improvement. How well are you doing with making disposition choices? How well are you doing with a caring tone and connecting and engaging with the person? Those types of things that are outcomes that you can measure. Safety measures, obviously, for call lines are important in terms of making sure that you're getting the right disposition for that person's need. And then disposition outcomes is the final bullet point on that. And that is, again, like we talked about early with Tara's question, is measuring how well you're doing and helping people with active engagement use the least restrictive outcomes. So that's it for call lines. Let's go on to mobile teams. So again, in our mobile team, our goal is to go out anywhere in the community, see anyone who's in crisis that has needed that escalation to a mobile support team support, be able to be coordinated with law enforcement or EMS. But the goal is, and this is in real life how it happens, the majority of people don't need law enforcement backup, and mobile support teams are able to go and engage, work with, and do a more full assessment than you can do on a call line, and oftentimes, and most of the time, be able to help that person settle their crisis in their community and connect to appropriate follow-up. So measurements are all about access of this service and effectiveness of this service. So let's go to the next slide, Joy. So again, same criteria, but here's a difference. So accessibility for mobile teams is about the dispatch time, when you get the dispatch from 911 or dispatch from 988 in the future, how long does it take for your team to get to on site and see the person? And so that becomes a really important measure. And as you can tell and think about it, it can be very different depending on whether you're in a rural or urban area, and times and standards for what's an acceptable time changes depending on distance that's required to go see people. And there's different models. You know, do two different staff members arrive in different cars and meet up to then go see the person? Do two staff members stay in a car that are on call at night and drive together everywhere they go? So there's lots of different wrinkles of how this is done in different places, but the outcome that you want to measure is that accessibility of care. One other aspect about accessibility that ties into staffing is your staff has to be trained to be able to support and interact with lots of different types of crisis situations. So you're going to run into child situations, adolescent situations, folks with intellectual developmental delays, and other kinds of situations, substance use, all kinds of things mixed together. And so they have to have some basic understanding of assessment and interacting and engaging with folks. But some of the things you see in other states that they use to help bring some certain subject matter expertise to the system is, you know, using tablets or data on virtual appointments to maybe reach out after a team sees someone in the community for someone with expertise in IDD to give support on that, for example, or to speak to specialists on call for the whole team to be able to do that. So I think you'll see models like that in staffing and training to help support teams as we go forward.
And Chuck, you just reminded me, I know we've gone past the call center service, but you just reminded me on that child adolescent kind of accessibility. I know North Carolina is piloting right now. I think we're about 7-8 weeks in about that text and chat feature. And being able to have that as an option for adolescents to reach out for support as well. It's only open for about 8 hours a day right now. That staffing thing is a piece of that. But over that time frame, I think they've seen more than 3,500 individuals reaching out. Just through the chat and the text feature. So that's another part of accessibility.
So true. And then going forward on these other ones, again, same thing that we talked about with the call lines is measuring the quality of your engagements through persons served, doing satisfaction surveys, looking at the quality of their assessments, evaluating the percentages of people that are able to be diverted from going to a hospital to being able to remain in their community. And then obviously safety is all about looking at outcomes related to mobile support teams being able to have good dispositions, safety for the staff that's working there, appropriate coordination and disposition choices on whether or not law enforcement needs to be involved in that community presentation or not, and things of that nature. So finally, we'll go to the last stage of clinical service, which is the community-based model of oh, I'm sorry, it's the next slide. It should be our crisis receiving centers. And the goal of them, remember, is to be just like the emergency room, no wrong door, be able to see everyone that comes in. And so what are some of the outcomes, Joy, that you guys are really leaning in on evaluating in these categories?
I was about to say, you're taking over my section of the presentation. So with the crisis receiving center outcomes, again, looking at these same 5 kind of areas, but looking at it from that facility perspective. So accessibility is just number one. If individuals find it difficult, if your stakeholders find it easier to take someone to an emergency room versus that facility, then that's what they're going to do. If law enforcement finds it easier to take someone to a detention center versus the crisis receiving center, that's what they're going to do. So making sure that your referral sources, individuals that encounter individuals that are in the community that need that support, whether that's mobile response, whether that's the call center staff, if they're not able to access the services at the facility easily, then that becomes not a resource for them. And then for individuals who maybe their family members are going to bring them in, maybe they're going to walk in themselves. Chuck likes to call it the easy button. If someone comes to us, meaning that if they're able to make their way to a crisis receiving center, then it is our obligation to make sure that they are served. So utilizing that no wrong door model, making sure that there aren't a long list of criteria utilized to screen people out, and making sure that there is a long list and levels of resources that can be offered from that facility. Not everyone that arrives will be there for 23 hours, for 5 days, but being able to ensure that when individuals do present, that they have that immediate access to care. And that requires, again, staffing. If individuals have higher acuity, if individuals have a substance use concern, but the next individual has a mental health concern, the next individual has co-occurring, all of those things require expertise. So making sure not only that there's adequate staffing for safety, but then also there is adequate staffing for the expertise that's needed. And here, a significant peer support staff is really important to make sure that environment is very treatment friendly, and then also thinking about that cultural competence piece as well. And then quality of services, having those metrics that you are looking at routinely to make sure that not only you have a service, but that service is serving the community. You have quality of care. You have key performance indicators that are being watched weekly, monthly to ensure you're meeting your targets. That can be overall presentations, that could be about diagnosis, quality of care, that can be disposition. There's a whole host of key performance indicators that can support just looking at the quality of the services that you are providing. And then
Joy, what would you say some of our key ones that our leaders at sites at crisis receiving centers are especially zoned in on to follow consistently?
Oh, absolutely. They're like, ingrained in the back of my head. Census and overall presentations, we look at the importance of serving more people with care. So if we are an empty facility, that means that we're not actually serving the community. So making sure that we are watching our census and making sure that we are serving individuals. And then average length of stay. So not only that we're serving individuals, but we're serving individuals in the time frame that is appropriate for them. If individuals are staying too long or too short, on one side, we're not providing them the care that they need for the entire crisis that they have, or we are keeping them longer than needed, and we are not able to serve another person who could be utilizing that space. So those are two, along with our occupancy rates. We look at our customer satisfaction surveys. We look at our door to dock time, meaning that how long does it take for someone to present to us and then to be seen by a professional. So that's another area that we look at as well.
Cool. Thanks, Joy.
I don't think I missed any. I'm used to spitting those out often. And then I think lastly, we look at, are we filled with the right people? Meaning that, are we serving our community stakeholders? As a hospital able to get access for people to be able to come into the facility? If they go to the ER first, are they able to then transition them over? Our first responders, are they able to bring someone to us? And that includes a mobile response. So we also look at our referral sources to make sure that we are serving our community. And then hopping down to safety, we look at safety in two ways. Safety for our staff, that we are looking at asking a random sample of staff at the end of their shifts, how safe did they feel today? Looking at our incident reports, and all of those things to make sure that we are providing a safe environment for our staff as well as our guests. And so for our guests, looking at how to add in those extra safety features and de-escalation and facility and all of that, anti-ligature features, to make sure that our staff, our guests, no matter what challenges that they are facing, are in a safe environment for them, but it's also welcoming as well. So finding that balance. And then when you're accessing a crisis receiving center, it is a very short length of stay. We are really focused on addressing that immediate crisis. And so looking at disposition, are individuals reaching their next level of care, whether that's residential, outpatient, ACT teams, all of that. And if they're not reaching their next level of care, why is that? Doing follow-up calls to see how things are going. So all of those things, just looking at not only to the end of their stay in the crisis facility, but did we do our job for them to make it to their next level of care within an appropriate time frame? Because we know within that 7-day period after someone is discharged from a facility is a really important time. No matter the challenge that they present with, for them to be connected through a warm handoff or immediate access to their next level of care.
And then I think our final, we've got two final slides before we go to our final discussion. And when we've talked about, I think it's the next one, Joy, is technology. So the use of technology that we use in all three layers at call lines with mobile teams, well, you can just hit all the bullet points, please, Joy. These are technologies that are going to be important pieces to help support that. And it includes things like GPS location, metrics for being able to look at these KPIs. Do you have analytical tools that can create dashboards and evaluate those kinds of things? Do you have bed board access? Some states have and communities have areas where inpatient beds are tracked in real time so that someone on a mobile team or a call center can actually help connect people into where the beds are to help them get out of an emergency department or out of the community and into a supported situation as quickly as possible. There can be real-time outpatient referrals done technologically where people have openings for appointments and can be able to get directly at 2 o'clock in the morning with a mobile support, have an appointment set up for the next day, already scheduled through the technology patterns that you have with that. And then there's safety features in the technology that you can use in terms of mobile support being able to activate support with a button where they need something like that, and all kinds of other options that are going to be an important part of helping both measure outcomes and achieve outcomes in these next steps. And then I think the last side is a final reminder, even though we've been talking about it in all the different steps, Joy, on about the importance of, if you serve everyone, it's all the different factors that you put into place to make sure that we're looking at outcomes related to different demographic groups, and that are we creating an engaging and effective and so caring environment for everyone. Something we missed for many, many years in the development of 911, and you could argue that we still got room to go there too. But it's really important as we design our systems from the start in 988 that those lenses are there, and that people with lived experience and people of all kinds of different demographic groups have input and voice into how our system works for everyone.
Absolutely. And we've hit on several different kind of groups in different areas, and talked about the importance of thinking about how to provide that access. And then once the access is there, having that cultural competence and expertise in the treatment space as well. And so we're not talking about developing a system that's only for some, but really thinking through how do we develop a system from start to finish that really impacts the community that it's supposed to serve. And that would include everyone. And that takes just a little bit more planning and creativity and thinking through how that's done. And it can be done. And it starts with that access and making sure that individuals, however they present, however they call, have access to those needed resources as well as everyone else. What's next? How are you going to take all of this information and then utilize that information to influence your systems that you have today? What are the areas that you feel are will be the most impacted? Where should you start? What's the most priority? And then if you're working to implement the system, where is again the best place to start? Because like 911, the system wasn't just, number was turned on and everything was great. It was really built over time, but it takes that thought process and roadmap and details to continuously work to improve this system over time.
That overall, no matter what area you are in that crisis continuum serving people, that we can change the system so that everyone has a sense of being cared for when they're in crisis versus what we have today. That's the one thing. If I could sum it all up, it was just that when you're in crisis, you can reach out to a situation that actually feels caring. When you're talking about violence, one of the things in crisis that's so important to create that caring and access concept that Joy talked about as well is, people always are worried about the safety aspect and violence aspect and how that affects being able to connect and support people. And I will tell you, it's always a tension between keeping your staff safe and keeping the people you serve safe, but not letting those be barriers to reaching out, connecting, and caring to people. And it's just a tough tension all the time, because there's that balance between risk versus comfort and choice. And the more comfort and choice and the way you can treat someone like a person and a human being, the more likely you're going to be to stay safe and help them stay safe. But there's always rules and things out there that can be a tough challenge to balance, is what I'll say.
Absolutely.
I think it's time to move into our poll questions. And at the bottom of the slides are just a lot of different resources of different outcome. This is NSPL's Crisis Call Center Matrix. CrisisNow.com has lots of different articles and Crisis Talk about different initiatives and innovations. Zero Suicide has multiple different pages and resources about suicide safer care.
If you would like to receive technical assistance, you are welcome to do that on our website. We thank you for attending today, and we appreciate you. We appreciate our presenters and the knowledge that they bring into this space. It is so valuable, and this series has had so much impact. Thank you so much.